Hi everyone, my name is Parshva Salvi. I'm a fourth year medical student at Wayne State University School of Medicine, and here I am presenting a cool case that I saw during my radiology rotation. So here we have a case of a 45-year-old female who presented to the Henryford Hospital with 2 days of abdominal pain worsening over the past day. She complained of pain that is localized to the left lower quadrant without any radiation, and she has been tolerating oral intake without nausea or vomiting. However, she notes that the pain worsens with eating or drinking. She denies any recent sick contacts or any history of travel. In terms of review of systems, she is negative for weight loss, fever, chills, and fatigues. However, she is positive for abdominal pain. She denies any hematochezia, melena, diarrhea, denies any constipation, nausea, or vomiting, and rest of the review of systems is also negative. Her past medical history is significant for hypertension, antiphospholipid syndrome, and small bowel obstruction. She has had an appendectomy, a C-section, and an X-lap in the past. She takes Coumadin and aspirin and has no known drug allergies. Her family history is significant for lymphoma in the mother and cancer in maternal aunt and uncle. For social history, she has a 10-pack-year smoking history but quit recently, and she denies any alcohol or drug use. On presentation, she was hemodynamically stable with a blood pressure of 132/81, heart rate was 85, temperature was afebrile at 97.5, and her SpO2 was 100% on room air. In terms of her labs, her hemoglobin was slightly low at 11.9, WBCs were 11.5, platelets of 574. Her BMP was within normal limits, LFTs was also within normal limits with albumin of 3.6, which is slightly low. Lipase and lactate were also within normal limits, and her coagulation profile showed INR of 6.08, PT of 53.5, and PTT of 73. Based on all the information that we had so far, here is a list of differential diagnoses. First is diverticulitis, which is common in this age group. She also has a classic left lower quadrant pain, leukocytosis. However, she does not have fever, but mild or early cases may present this way. Second on my list is small bowel obstruction. Given that she has a prior laparotomy, C-section, and appendectomy, puts her at high risk for adhesions. However, SBO is typically associated with nausea, vomiting, and constipation, but sometimes early obstruction may not present that way. And she also has pain worse with eating, which is consistent with SBO. Third on my list is acute mesenteric ischemia. She has a history of antiphospholipid syndrome, which is a hypercoagulable state. And she has abdominal pain out of proportion to exam, which is a red flag for acute mesenteric ischemia. However, her lactate is currently normal, but early disease may not show elevated lactate. Next on my list is ovarian torsion, given that she had acute abdominal pain, left lower quadrant, and she could have pelvic adhesions because of her history of abdominal surgeries. However, her pain has been present for 2 days and worsening gradually, whereas torsion presents with abrupt severe pain, so it's lower on my differential. Uh, Finally, I have inflammatory bowel disease, which can cause microcytic anemia. It can cause left lower quadrant abdominal pain and thrombocytosis, which are all seen in this patient. However, she does not have any bloody diarrhea, and the presentation at the age of 45 is uncommon, and she also does not have any systemic signs. Given her presentation, a CT angiography of the abdomen and pelvis was also ordered that showed acute complete occlusion of the distal superior mesenteric artery after the origin of 5 branch vessels. The CT scan also showed a non-enhancing loop of small bowel within the right lower quadrant, likely within the terminal and the distal ileum, extending for at least 10 centimeters. The findings were consistent with acute mesenteric ischemia. So, based on the radiologic findings, this patient has acute mesenteric ischemia secondary to SMA thrombosis. SMA thrombosis accounts for approximately 25% cases of acute mesenteric ischemia. Some of the common causes of SMA thrombosis I have written on the slide. One of them is in situ thrombosis from underlying atherosclerosis. Another one is embolic occlusion from conditions such as AFib, endocarditis, or post-MI mural thrombus. Another cause is hypercoagulable state such as antiphospholipid syndrome as seen in this patient, and another hypercoagulable state is malignancy, and it can also be from vasculitis. All of this results in bowel hypoperfusion, which can lead to ischemia and further infarction if left untreated. For the diagnosis, the gold standard is CT angiography for SMA thrombosis, and you will see filling defect in the SMA. You might also see some bowel wall thickening, which may indicate ischemia. There will also be reduced or bowel wall enhancement. There can also be pneumatosis intestinalis and mesenteric fat stranding. So there are different ways you can manage acute mesenteric ischemia secondary to SMA thrombosis depending on the severity. The first step is anticoagulation. You can start the patient on heparin and then bridge to warfarin. There can also be endovascular interventions done such as thrombolysis, mechanical thrombectomy, or stenting, and the definitive management is bowel resection. The outcomes are linked closely to the timeliness of diagnosis and revascularization. Early diagnosis and treatment can lead to favorable outcomes. However, delayed recognition increases the risk of transmural bowel infarction, sepsis, and multi-organ failure. Prognosis is particularly poor when there is radiologic or intraoperative evidence of bowel necrosis. Here's the list of references. Thank you everyone for listening. I hope you enjoyed it.